we'll have some cups coming soon so that people can grab some water. We don't have beverages, but there's a water fountain just outside. I'm not entirely sure what each of the things are. Why is this not working? Okay. Huh. All right, let's try this again. Maybe I can put it. Let's try this. Oh, good. That's easier. I think we'll start in about 5 minutes. We'll let a few more people kind of come on in slowly. Sonia, you made it on time.
Yeah.
Did you drive in today?
No, I had to go to the DC office to take care of something. Take a breath.
Wait, the DC office of?
Go to one of their government offices.
Gotcha.
Mm-hmm.
Oh, thank you.
I just got from.
Yes, thank you. Thanks for bringing them in. Yeah, just in case people. I think there's just a water fountain somewhere. Yeah, so there's a water fountain just outside. Just gonna go out and turn to the left, and you'll see it if you guys wanna. You need cups for water. How are you feeling? Are you? It's a tough time to feeling under the weather at the end of the semester.
Yeah, I just had to wait. So, for
We'll definitely try the best as much as you can. I know you have to do lots of studying and other things now.
the end of the semester.
It's stressful.
My body just decides to deteriorate at the end. I should learn how to not let this happen.
I mean, with all the stress, I mean, getting to exams and yeah, just getting to the end of the semester as well. It's a long,
Yeah.
like 14, 16 weeks, or however long it is. It takes a while. It's a lot on the body. Well, thanks for coming. Hopefully you'll have some food or get some water. Take care of yourself. All right, so we're expecting about 12 people. Feel free to grab food. We're not starting right away, so feel free to get some food. And there's also cups for water. The water fountain just outside to the left. All right, has everyone had a chance to grab food if you'd like any? It's last chance before we start. I mean, this is be pretty informal, so feel free to go in and out at any time. I'll get started because about 10 minutes after. I think this microphone's working just, but I don't know if I need it either. This is being recorded, just to let you know that. So I'll get started. My name is Sean Bland. I'm a senior associate at the O'Neill Institute for National and Global Health Law, and that's based here at the Georgetown Law Center. I've been working at Georgetown for about 3 years, but I have my connection to the university goes back even further. I got my JD here, graduated in 2013, and came back after practicing for a few years. And my background, even before I came into law school, was around kind of HIV prevention and treatment issues. And I came to law school so I could kind of focus more on kind of the legal aspects and policy aspects. So I'll just give a very brief overview first for O'Neill. I think most people here have some affiliation to Georgetown or to the Law Center, but the O'Neill Institute has been in existence for over 10 years now. Last year was our 10th year anniversary. We were founded here at the Law Center, and actually when we originally were founded, it was a collaboration between the law school and the nursing school. And so we kind of work at the intersection of health and the law. And we work in a lot of different areas, one of which is infectious disease, which is the area that I work in. But we also work on non-communicable diseases, health and human rights, healthcare delivery, food and tobacco, food and drug regulation, global health governance. So we have 7 kind of key areas that we kind of work in. So it's not all focused on HIV, but HIV is the main focus of my work within the Infectious Disease Initiative at the O'Neill Institute. And most of the work that I do is focused on HIV law and policy in the United States. Particularly focused on HIV treatment issues, so things like the Ryan White HIV/AIDS program, which we'll talk a little bit more about in this presentation. which is really at the backbone of the kind of HIV treatment response in the United States. I work a lot on HIV prevention issues, so high impact prevention, how to make prevention modalities like pre-exposure prophylaxis or PrEP, post-exposure prophylaxis or PEP, things like that, accessible to communities most impacted by HIV. And then I also do a lot of work at the intersection between HIV and criminal justice. And all of these issues are going to kind of come up as we talk about the subject of this presentation, which is innovative approaches to HIV treatment and prevention, where we are now, and why we need to be talking about policy. And so if you saw the kind of announcement for the event, we're going to be talking about 3 topics in particular. The first one is molecular HIV surveillance. The second one is looking at research around kind of new forms of HIV treatment, particularly long-acting forms. So rather than taking a pill a day, these are new modalities that can, I think, really improve adherence to medication as well as quality of life for a lot of individuals living with HIV, as well as those who want to protect themselves from contracting HIV. And then the kind of the third issue we're going to talk about is how to get people into care as soon as possible, because that is actually something that we see a lot of the kind of the gaps where we see disparities in HIV. It's not being able to connect people to care and keep them retained in care. And so if we're able to do that faster, that has, I think, a lot of benefits that we can think about. And I'd love to, for this kind of conversation, it's going to be part presentation, but please ask questions. If you've worked on HIV issues, if there are things that you're interested in, I'd love for there to be discussion on all of these topics. All right, so I'm going to first talk about molecular HIV surveillance. And I'm not going to jump right into molecular HIV surveillance, but rather give some context. And so I really want us to be thinking about kind of how we use emerging public health tools and technology to make progress on HIV. So whether it be to engage people into HIV treatment if they're living with HIV, or to prevent new infections. And technology is changing. We're in a time of technical change and innovation, and it's very exciting. It's creating new opportunities to better support all people living with HIV, to live long and healthy lives, as well as, again, to reduce new HIV infections in a dramatic way. So there's a lot of promise to using public health tools and technology, but they also come with some risks. And it's, I hope it's not new to anyone, but stigma and discrimination are very much alive and well, particularly around HIV. And some of the same tools that can be used to kind of make HIV progress can actually enact some harms if we don't use them in the right way and if we don't have protections in place. So I'm first going to talk about big data and kind of just what we mean when we talk about big data, because you can situate molecular HIV surveillance within kind of big data. And then we're going to talk specifically about molecular HIV surveillance. So what do we mean by big data? Well, it can mean a few different things. I mean, when you just think about kind of the advent of the internet, the transition to the internet, to kind of more dynamic user-generated models that kind of have resulted in an unprecedented amount of data. So there's data that exists every time you click on a website. So all of that kind of metadata exists in the world. In addition to that data that's kind of just collected incidentally, just when you're doing many things in the world, big data can also refer to intentionally produced data for the purposes of improving health or doing any other type of outcome. So when we're thinking about health, we're thinking about repositories of genomic information, collections of medical records, things like that. So we have larger storage capacity, we have greater processing power, and more power to do analysis that allow for us to identify correlations and also to draw other conclusions from big data, and so the data sets that include big data. So what are some of the implications for big data, the implications of big data for HIV? Well, again, I want to talk about this in terms of both the promise of big data as well as some of the perils. So the promise is we can do personalized medicine, which is very exciting. So when we think about HIV, we can do genotype resistance testing for HIV to identify what's going to be the best course of treatment for a person living with HIV. So rather than giving them a med that they'll be resistant to, or that will not work very effectively for them, we can get them the best kind of medications, and we can do that based on genotype testing, genotype resistance testing. We also can use big data in the context of research. So big data allows researchers to discover correlations and to draw conclusions that just wouldn't be possible if we didn't have large data sets and the kind of analytic tools that exist nowadays. On the other side, what are some of the potential perils of big data? Well, from kind of these small, individually kind of insignificant inputs. So again, whether it be metadata from your computer or kind of browser history kind of searches, things like that, you can use data analysis to uncover a large range of very private information about individuals. So again, on their own, some of these things are going to be very innocuous. So a user searching for HIV-related terms on Google, visiting Amazon to buy books on medical supplies, posting certain things on Facebook. But again, that's only a piece of the data that exists out there. And once you kind of aggregate all that data and you analyze it, you can tell a lot about someone. Particularly once you start looking at timing of data, like when people are accessing things. It can reveal a lot about someone's personal health or just their personal lives. Large data sets also that are stored electronically make large-scale privacy breaches also more likely. So not only there's this data that's out there that is showing information, it's also housed someplace, and sometimes there are breaches in that data, and so information gets out or it gets out to the wrong person, again, accidentally, but that also has a lot of consequences, particularly when you think about things like health information. So if someone's HIV status were to be disclosed or some other information about their health information gets disclosed. So what is molecular HIV surveillance? So molecular HIV surveillance involves the collection and the analysis of HIV genetic data to support health departments in identifying HIV transmission patterns within communities or within sexual or drug using networks. And kind of using that kind of collection of information and that analysis, health departments are able to intervene to prevent further transmissions of HIV. So where is this molecular HIV data coming from? Well, just as a part of regular HIV care, healthcare providers order drug resistance testing to learn more about treatments that would be good for people living with HIV, what's going to be the best for their particular strain of HIV. That drug resistance testing involves determining the genetic sequences of the HIV virus. So it's not of the person, but the genetic sequences of the virus that the person has. That HIV genetic data is sometimes called molecular surveillance or molecular data, and it's reported to health departments by healthcare providers and also by labs that do the resistance testing. And the health departments analyze that data to see if there are connections between different people in the community. And so they're looking at how closely related nucleotide sequences are for people living with HIV. And that information is very powerful. It can help them to identify and to target effective prevention interventions, particularly where we're seeing new clusters of HIV infections or places where we're seeing a growing number of HIV infections. So what does it mean when two nucleotide sequences are closely related? This is a little bit to do with just like causation versus correlation. So it can mean a few things. It can mean that, say, person B got HIV from person A. It could mean person A got HIV from person B. So there could be that direct connection between two people. But there also can be indirect connections. So it could mean that there could be someone in between person A and person B. So say person C contracted HIV from person A, and then person B had sex with or had contact with person C and contracted HIV. So there could be that kind of indirect connection. Similarly, there could be some alternative person D who is the person who transmits HIV either to person A or to person B. So again, we can infer that there is some type of epidemiological link, either direct or indirect, based on these nucleotide sequences and how closely related they are, but we cannot infer directionality. And I'm talking about directionality because that's something that, while not necessary for doing public health interventions, in fact, I think we can do a lot of good public health work through health departments based on molecular HIV surveillance without knowing directionality. Directionality is something that comes up, particularly in the context of kind of HIV criminal laws, which we'll talk a little bit about as well. And that's one of the kind of main concerns about how this data might be used, particularly if it's ever released to law enforcement or if it's subpoenaed by law enforcement for a criminal case. But again, right now, we don't have the ability to track directionality. With greater science, with scientific developments, that could be in the future. Or you need to be thinking about directionality not just in terms of molecular HIV surveillance, but what about all the other information that you know about people? So like when they first tested positive for HIV, when they had sex with someone, when you look at it in the context of other information, connecting that with molecular HIV surveillance data, it's not necessarily guaranteed directionality, but it kind of starts to suggest it a little bit more, and it could be used in ways that could, again, lead to real harms for people living with HIV. So, when we talk about molecular HIV surveillance, I think this is, again, an emerging technology, particularly when it's connected to, public health activities. Yeah.
Sorry, I'm just curious. Is the research that focuses primarily on trying to establish directionality? If yes, what is the why are they trying to establish that?
So, as I mentioned, for public health purposes, I don't think you need directionality. There are a lot of ways in which you can use this molecular HIV surveillance to see whether, say, there's a new cluster of HIV infections. So, 5 new HIV infections in a particular neighborhood of DC among Black, gay, and bisexual men, where that's happening, and that's happening in a short period of time, within a matter of days or weeks. That's a place where we need to go in, intervene, do education about distributing condoms, access to PrEP, things like that. So you don't need to know the directionality to know, hey, there's a new cluster of infections. We need to intervene, or we need to investigate to see what's the cause of those kind of new infections. But directionality is something, again, that could be used in, say, a criminal case. So it's not important for public health, but even as public health is operating in its own kind of world, we have laws, criminal laws that exist in the United States and 34 states. Prosecutors can go and they can subpoena the health department and ask for all records that you have with respect to a particular defendant in a case. And they might try to see some type of direction between that defendant and the person that they're bringing the case on behalf. So, they will say this person gave HIV to this other person, they didn't disclose their HIV status. We want to see that we want to prove that that person got HIV from the defendant, and that's going to be part of this case to show, not only did they actually infected the person, but that they actually intentionally did it, or they did it without disclosing their status. For public health purposes, you don't need the directionality. That's not to say that, again, the science is not evolving in such a way where we could at some point, get closer to directionality, and that might be of interest in some cases to researchers or other people. But yeah, you don't need it for, to see benefits from molecular HIV surveillance. But again, this speaks to the perils that are out there, where if we're not protecting that data, if we're not we're not working with health departments so that they know when to resist subpoenas, when to not disclose that information, making sure that we're working with legal counsel so that that information just isn't just being used in ways that it wasn't originally intended to be used. Again, molecular HIV surveillance is a kind of a newer tool that's out there, but it's just one of many tools that health departments have to investigate new HIV infections, new clusters of HIV infections in communities. What are some of the other tools that are out there? Well, kind of really at the front line are providers and communities. So, when providers are seeing new infections happening among a particular population, they are often in contact, and they let health departments know about that so that they can respond and to address it, whether it be among trans populations, so trans women of color in Southeast DC, if they're health providers there and they're seeing a lot of people coming in testing or actually being diagnosed with HIV. They can, let health departments know that, hey, this seems to be kind of an issue that needs to be addressed. We need to be focusing more on that population. Communities as well. So there are, communities of gay men, trans individuals, people who use and inject drugs. Health departments engage with those communities, kind of learn what their kind of HIV treatment and prevention needs are. So they're learning from those communities, and they can adapt their approaches, just learning directly from the people, providers, and community stakeholders. There's also surveillance data that's out there. So when people are diagnosed with HIV in the United States, you go to your provider, you test positive for HIV. The healthcare provider is obligated in all the states in the United States to report that information to the health department, as are laboratories that do the testing. So that is really the routine HIV surveillance data that health departments get, and then they report that information to the CDC, and that's how we have our reports each year to say, are we getting new HIV, increases in new HIV diagnoses or not? So in addition to hearing directly from providers and community, there are these surveillance systems that are in place that are really important for kind of seeing new trends in HIV.
As far as healthcare providers are concerned, assuming that somebody does have insurance, have there been any issues with people being denied, coverage or treatment once they test positive for HIV?
Yeah, so it's a great question. It has been historically, and it still is. There's still issues. prior to the Affordable Care Act, which eliminated, pre-existing conditions as being kind of like if you have any type of pre-existing condition, including things like HIV, private insurance would say either we're not going to cover you, or we're going to, so they'd have like a blanket exclusion from their policies, or they would charge you a ridiculous amount of money that you just could not afford, so you couldn't get private insurance. So that was, I think, a major barrier for many people, not just focused on HIV, but many people. So the alternatives were either if you were low income and you had HIV, which prior to the Affordable Care Act, which allowed for Medicaid expansion, and now most states have expanded Medicaid. We still have 18 that have not. That you could, in many cases, qualify even prior to ACA expansion for like Medicaid in many states if you were poor enough with the HIV diagnosis, which could be treated as a disability. Outside of that, if you're older, you might qualify for Medicare. And then for HIV, we have a program that is the Ryan White program, which is an HIV-specific program, and that has been known as the payer of last resort. So it's been around for 28 years, since 1990. That has provided HIV medications, but increasingly, rather than just medications, the Ryan White funds have been used to pay for insurance for individuals. So for people who are uninsured or underinsured, to help them to pay for co-pays, for cost sharing, so whether it be co-payments, deductibles, things like that, to help people to be able to have healthcare. So they'll have access to HIV medications and then access to a provider, but also all comprehensive healthcare. They'll have access to insurance. So that's kind of been the way that the Ryan White program has evolved over time to help people living with HIV to have insurance. And it's still serving that function today, even after the Affordable Care Act. So the Affordable Care Act has eliminated the pre-existing condition. So now people can, buy health insurance on the individual market if they don't have an employer. Obviously, it's very expensive still for many people. The Ryan White program kind of helps to help people to afford that. And obviously, we also had with the ACA expanded Medicaid. So for the states that have taken that option, obviously it became voluntary with the Supreme Court decision. Medicaid is now, it's one of the largest providers for people living with HIV, along with Medicare. There's still kind of cost sharing issues that kind of come up with, particularly with Medicare, that, the Ryan White program helps to allow people to afford medications and afford treatment. And then even for Medicaid, it's a great program. It's really, really successful. Most people on Medicaid still rely on the Ryan White program for certain services, some things that just aren't covered by insurance. So whether it be extensive kind of case management, patient navigation services, transportation services, things like that aren't necessarily always covered by private insurance, but even by Medicaid, the Ryan White program plays that role. So that is a special program that exists for people living with HIV. It's dedicated for people living with HIV and continues to play a big role. And we'll get back to it when we think about what role it can be playing in terms of not only covering care, but making sure that we can get people onto treatment as soon as possible, because we know you have better outcomes if you can get people on treatment sooner. So just, again, trying to situate molecular HIV surveillance and all these other activities. We talked about providers and community. We talked about HIV surveillance tailored through HIV diagnoses. There's also this thing called partner services. So health departments in all the states have disease intervention specialists. That's the title that they have. When there are new diagnoses reported to the health departments, the health department often will reach out to a person living with HIV or someone who's diagnosed with some other form of sexually transmitted infection, and they'll say, hey, we're happy to help notify your partners. So partners that you may have had since you think you contracted HIV, we're happy to go out there just to tell them, go get tested. It's a way to prevent new infections from spreading for people who are recently infected and who don't know. So that's another tool that health departments have been using for some time. And then in addition, molecular HIV surveillance is adding hopefully some additional value there. So what do health departments do with molecular HIV surveillance data as well as other surveillance data? Well, they can find groups in which HIV is spreading quickly, either because they're in a similar geography. So say you're all in the same neighborhood or even the same block. So you can kind of get really granular there to see where is the specific place where we're seeing new HIV infections, what's going on there, how can we intervene. or because diagnoses are happening around the same time. So even if they're in different parts of the city, if they're all happening around the same time, say within a week of each other, hey, maybe people were moving from one part of the city to the other to meet sexual partners, having sex, or part of a drug using network. That's happening. How can we kind of intervene there? What's going on? And molecular HIV surveillance can help to fill in parts of that story and help to inform prevention interventions. Again, there are also other epidemiological characteristics, but it can help to see whether HIV is spreading quickly. But also, they can help find groups because they have genetic strains that are closely related. And again, that's kind of looking at how closely related those two nucleotide sequences are. So once you have that information, you can start to reach out to networks. So you can start to provide services where they're needed. It can help you to start to do your own investigation to better understand barriers that people are facing to accessing HIV care as well as HIV prevention services. And you can also help to develop approaches to help people overcome those barriers and help communities overcome barriers to both treatment and prevention. So I just want to give a case study around molecular HIV surveillance just so you can kind of see what really how health departments use it. So I'll give two case studies. The first one's situated in San Antonio, Texas. So there was the molecular HIV surveillance helped to identify a large molecular cluster among Latino, gay, and bisexual men and other men who have sex with men. So that's MSM. So the investigation demonstrated situations in which improper testing led to misdiagnoses of acute infection. So acute infection is right after you contract HIV. You often have a heightened amount of kind of HIV in your blood. It'll often lead you to manifest symptoms that are similar to like flu symptoms. So you'll get a cold, you'll get a fever. It's a time where you're highly infectious because you have a lot of kind of HIV in your blood. So when you miss opportunities to diagnose those infections, it can lead to many new HIV diagnoses in a network or in a community. So yeah, they were able to use molecular HIV surveillance data to see connections between people and the timing of those connections, and to identify that, hey, we should have been doing testing when these acute infections showed up, because again, usually there are often symptoms there. We should have been connecting people and doing the testing in those communities so that people know their status, and once people know their status, they can take steps to prevent the spread of HIV to others. So molecular HIV surveillance was adding some value there. Based on that, a health alert was sent to providers, educating them about HIV diagnostic testing and about acute infection. So working with providers so that they know when people are coming in to make sure that they're doing the right type of diagnostic testing and are identifying people who have acute infection and making sure that they're counseling them properly, making sure that they are putting them on the right treatment regimens, all ways to hopefully get them to have better health, in terms of their own health. It's good for the person living with HIV, but also has a public health function in terms of, again, as I mentioned, people with acute HIV infection are even more infectious just because of the kind of state and the amount of HIV in their blood. You're likely to prevent new HIV infections by kind of just educating providers and having those providers educate the clients that they're seeing. The investigation also demonstrated a lack of access to PrEP. So a health alert was sent that educated on PrEP, and funds were redirected to scale up access to PrEP in specific regions of San Antonio. And finally, the findings led to a new coalition among community providers and public health, and it ultimately led San Antonio to sign on to the Fast Track Cities initiative. And this is a global initiative that really is focused on empowering cities. So cities in terms of city governments, actors within cities, to kind of focus on what they can do to address the HIV epidemic at a local level. So not thinking globally and not thinking at the national level. A lot of healthcare delivery and services happen locally, and there's a lot that can be done to fight HIV locally. And Washington, D.C. is actually a fast track city. It's one of the first cities in the United States to sign on as a fast track city. And so you have Mayor Bowser, the D.C. Council, other stakeholders in D.C. Kind of based on, after signing on to fast track city, they've moved to develop, an AIDS strategy. They've signed on to the World Health Organization's 90-90-90 plan, which is kind of a metric and kind of a goal to make sure that 90% of people living with HIV know their HIV status, that they are engaged in care, and that they're virally suppressed. Because we know when people are virally suppressed, they have the best health outcomes. They're also not able to transmit the HIV virus to their partners. And so those are things that happened. It really led to kind of just a mobilization within San Antonio. Another case of molecular HIV surveillance, it identified an increase in HIV diagnoses among people who inject drugs in northeastern Massachusetts. So providers identified multiple clusters of increased diagnoses in Massachusetts. So routine surveillance data, so again, when HIV diagnoses are reported to health departments, it provided a broad epidemiological profile, but molecular HIV surveillance is what showed that members of all 3 epi clusters were part of one larger transmission cluster. So again, these clusters were happening in different parts of the state, but you could actually see from the molecular data in terms of how closely related the nucleotide sequences of different people in those different clusters, how closely related they are. You can actually see they weren't 3 separate epidemiological clusters, but they were all connected. So people were moving around, having sex with people in different parts of the region, and you could see that connection and start to investigate that a little bit more to kind of know what's going on and what's leading to new infections, and who particularly, what population, so people who are injecting drugs, are seeing the increases in infections. So molecular clusters included a large number of people who were not identified as part of kind of your general routine surveillance epi data. So again, it's adding something that was not there from those other branches. So when providers are reporting things, when you have routine surveillance, when you have partner services, those are all important tools for doing HIV prevention, doing public health, but molecular HIV surveillance can add something additional. And it allowed for improved recognition of the scope and the connectivity of the situations in northeastern Massachusetts, and for an expansion of prevention efforts to a larger cluster population of people who are injecting drugs. So does anyone have questions about that, how molecular HIV surveillance, it does seem to have some value, and I think it's really important to articulate the advantages of this kind of surveillance data, particularly when we weigh that against what are some of the possible risks. So molecular HIV surveillance tools, as well as broader and related public health tools, also raise a lot of concerns about privacy and about consumer protection. So many of the communities most heavily impacted by HIV are under threat. I don't think that comes under surprise, and they're very much often under a threat from the governments that are there to protect them. So we know that we have significant disparities in HIV in the trans community as compared to the non-trans or the cisgender community. That's a community where we're not collecting health data on. We're not including them in the census. We have a president that has kind of is moving forward with a trans military exclusion. So it's a population that's already very much marginalized. Obviously, we know that there are transphobia, discrimination in employment and housing and all facets of life that the trans population face, and that's a population that's also under threat with respect to HIV. And so where government should be their protectors and doing more to support the trans community, they're just not. And so when we think about trans community, we think about gay and bisexual men, gay and bisexual men of color, people who use and inject drugs. Those are also communities that are heavily policed. So we know that there are criminal laws that are being used to arrest and prosecute and also differentially sentence people who are living with HIV purely based on their HIV status. We talk about these in the terms of the broader concept is HIV criminalization. So there are different types of laws that are used to criminalize people purely based on their HIV status. So that's, again, on top of all the other kind of things that people are facing, when you're also policed based on your HIV status, that's another threat that you're facing. So I mentioned before, there are 34 states that have specific statutes. So these are all at the state level in the United States. They have specific statutes that only apply to people living with HIV. So that's why we call them HIV-specific statutes. And usually what they require is that a person living with HIV disclose their HIV status to their partner. And if they don't, they can face arrest and prosecution. And we have a significant number of prosecutions still. So just within the last few years, we've had, most states have had prosecutions within the last 2 years. We've had some 300 arrests or prosecutions in the last decade. So they're still very much happening. And again, often these things, just in terms of a facet of the US system, where plea bargaining is very common, we don't always know necessarily all the ways in which they're being used. Sometimes they're added on to threaten people so they actually do plea to charges. So again, HIV-specific statutes exist, they're being used. In the states that don't have HIV-specific statutes, that doesn't mean that people living with HIV aren't criminalized. States use their general criminal laws, so whether they be assault statutes, reckless endangerment statutes. There have also been uses of attempted homicide. So based on having sex, just because you're living with HIV, prosecutors will bring charges of attempted homicide, thinking that HIV is a death sentence and that someone is either intentionally trying to transmit the virus and therefore, subject someone to essentially death. So they're equating that to attempted homicide. So those are also being used. So even where HIV-specific statutes don't exist. And again, as I mentioned, 33 states have had at least one prosecution in the past 2 years. Laws often criminalize people living with HIV based on not only based on non-disclosure statute, but they do it in contexts where there's no risk of HIV transmission or very, very little risk of HIV transmission. We know that oral sex, for instance, is very, very low risk for HIV transmission, and yet people who engage in oral sex will be prosecuted under these statutes. Even more ridiculous types of charges are pretty common, where people spit. Spitting, it could be the basis of being criminalized, and you could spend 10, 25 years in jail for spitting or biting. And a lot of those types of cases come in the context of resisting police arrest. I think you can kind of imagine a scenario how that might come up, but we know some communities are more police than others. We've seen in the news lots of cases where there are physical and even violent interactions between the police and often people of color, where again you could die at the hands of the police, and often without any consequences. But in a context like that, where you're trying to resist violence from the police, you might spit at them, you might bite them, you might do something like that. And if they're able to find out, either through health records or otherwise, that you're living with HIV, in some cases, people might even disclose that to the police officer if they, are facing significant violence. We're like, please stop, I'm a person living with HIV. And then they're like, oh, well, we know that you have HIV and you spit at us, or you bit us. Prosecutors will use that to criminalize individuals. So it's not uncommon. So again, those are situations that are happening. We also have states that make it a crime. Specifically, again, 11 states where we have had arrests or prosecutions based on spitting and biting. And then we also have 6 states that have mandatory registry as a sex offender after you've been convicted under an HIV crime. And even in states that don't have mandatory registry, it's still very much possible to be registered as a sex offender even after serving your years in prison. So there are heavy consequences that people face around HIV criminal laws. And so if this type of data were used, as we were kind of speaking, to either show directionality, so use of that data to identify linked molecular clusters raises the possibility that the public, particularly criminal justice, might, again, even if we can't right now detect directionality, they might infer that there's a directionality in a particular case. Lawyers aren't scientists. They don't understand this stuff. They'll still make that argument. And that can be the basis for someone being, convicted and spending a very long time in jail, and then facing consequences after that as well. And even if directionality can never be inferred, there's no way to defer it in any way. We know that lawyers and jurors may just wrongly infer that directionality. And there also just may be cases where, again, you can't guarantee that there's directionality, but you can use other data sources. So you have, witnesses who testify. You have other information out there that kind of help people to tell a narrative that makes it look like this person transmitted the virus intentionally or otherwise to someone else, and that can be the basis for a prosecution and a conviction. And again, as I mentioned, right now we cannot detect directionality, but science is changing very fast. And there are at least some scientists who think we can move in that direction, that we could have science out there that has a high suggestion that, of those two people who are linked, who gave the virus to whom. That's not the case now. And again, it's not necessary for public health interventions, but science kind of moves at its own way, and even as it's moving, that in the wrong hands, if it were to be turned over to law enforcement, used for these types of HIV criminal cases, it could lead to some very real harms for people living with HIV. There are also just broader privacy concerns that I think a lot of people living with HIV and HIV advocates have about just having all this information about your HIV kind of genetic sequences. That's private information that is in the hands of the government. And even if it's never used for a criminal case, do you want that information in the hands of the health department? They have concerns about how it will be used. As I mentioned, there are partner services that exist, which I think play a very vital role in terms of the HIV prevention response. But partner services, often are mistrusted. I mean, there's a lot of mistrust in a lot of communities, particularly, sometimes because of the interactions with law enforcement, but also just because of really negative interactions that people have with public health officials when they come to their houses to kind of ask questions about who their partners were. They do it in disrespectful ways. I've at least heard reports from people living with HIV where, at least in some cases, these disease intervention specialists that I mentioned who do the partner services, they'll go to your place of employment to kind of ask questions. That's very, you have like a government official coming to your job, regardless of whether or not people know that it's HIV specific, is very disruptive. It leads to mistrust. And so people have concerns about how this data is used. There are ways, again, to limit and protect the disclosure of molecular HIV surveillance at the federal level. Obviously, we know at least at law school, we know about HIPAA and the role that it plays in terms of protecting protected health information that's kind of transmitted between covered entities, so covered entities like providers, like insurers, and also healthcare clearinghouses, so people that collect a large amount of data. The thing is, in terms of reporting this information to health departments, there's a HIPAA exclusion or exception that allows for reporting to health authorities. And so, again, when this is something that's authorized at the state level, HIPAA doesn't really have anything to say or to prohibit that from happening. We have other acts of legislation, things like the Privacy Act of 1974, but it doesn't particularly apply to state and local governments. It applies only to the federal government. So again, there are federal laws that are out there, but they're not really kind of addressing some of the concerns around the use of this molecular HIV surveillance data. We do have the Genetic Information Non-Discrimination Act, or GINA. It's a federal law that prohibits discrimination based on genetic information in employment and health insurance. And GINA actually defines genetic information quite broadly. So it talks about genetic tests, it talks about the manifestation of diseases or disorders in family members, so you don't just have to have a genetic test, but it's quite broad. Still, at the same time, there are many cases where it's just not going to apply to molecular HIV surveillance. So what other protections exist? There are some protections at the state level, and often the protections that do exist or that'll come up most will be at the state level. So it's important to look at what policies exist at health departments, but also what laws exist at the state level. There are patient consent and notification provisions with regard to HIV surveillance data, but those types of provisions are very limited. We might want to see, given how molecular HIV surveillance might be used, some beefing up of those types of provisions. Most laws that exist at the state level don't explicitly address data sharing practices, including how health departments share data with law enforcement. Again, within HIPAA, there's an exception for sharing data with law enforcement. So if a provider or insurance company were to get subpoenaed, there wouldn't be a federal problem. Obviously, if it's not allowed under state law, they couldn't do it, but that would be an exception under HIPAA in many cases, not all cases, but in many cases. So you would need to have policies or statutes at the state level to kind of protect how that information is disclosed. Right now, we know that there's broad discretion among health departments and their legal counsels to make decisions about data sharing. So it really is one way to start to intervene, to kind of change how this data is used, is to really educate and to work with health departments and their legal counsels to say, what policies do you have in place in case you are subpoenaed for this data or you have a court order? How do you kind of address making these disclosure decisions and thinking about how they could be used to harm communities and to harm individuals? And we also just know, this is all kind of some data that's been done by the National Alliance of State and Territorial AIDS Directors. They've worked with all the kind of state and local health departments, state health departments and certain local health departments with their kind of HIV AIDS directors, they've done some research and they show that there's just a lot of variation in terms of data sharing practices, either with law enforcement or otherwise, at the state level. So you have states like Massachusetts that has no statute that authorizes the health department to release HIV surveillance data to law enforcement, but most other states have some type of law. And the reason why they have this type of law is because they have these HIV criminal laws that exist. And so when you have HIV criminal laws, states have often created an exception whereby health departments can disclose information to law enforcement. So what's the path forward? We are currently doing a lot of work on this right now. We've engaged with a lot of community stakeholders around these issues, hearing from people living with HIV, but also kind of working in collaboration and hearing from and engaging with local and state health departments, as well as with the Centers for Disease Control and Prevention. We're writing a report right now, and we see some kind of big things that we need to start to be addressing and having more work around are, just in a general sense, ending prosecutions based on HIV status and modernizing HIV criminal laws. In most cases, it's not a solution just to get rid of HIV criminal laws, because as I mentioned, there are these general criminal laws that exist out there, but making sure that we end prosecutions, making sure that we prohibit most disclosures of public health information to law enforcement, making sure that we strengthen compliance for data handling requirements, making sure everything is under secure, under the highest levels of security, and that this information is only accessible to those who need to know it. Working with communities to rethink standards and training for other parts of the public health kind of response, so particularly these disease intervention specialists, training them to do their job more effectively and to not alienate communities and to kind of feed into, again, mistrust exists, but it often exists for very real reasons. Educating key stakeholders about molecular HIV surveillance, as well as other activities that health departments engage in, and just continuing to engage with communities to hear about their concerns and what they think would be the kind of the best solution to these problems. So that's a very kind of good introduction on molecular HIV surveillance. We have a little bit of time left, and I want to talk about a few other areas that we've done some work in, and that we actually have some reports on. We released 4 reports this summer, and I have some copies for people who would like to take them on long-acting HIV treatment and prevention. So these are innovative products for that are currently under development. And the great thing about them is they wouldn't require taking a pill every day. Kind of the standard right now is that if you're living with HIV, or if you're taking something like pre-exposure prophylaxis or PrEP, you take a pill every day. If successful, these products wouldn't allow that. You wouldn't have to take a pill every day. You might take a pill once a month, or you might have an injection, or you might have an implant that would be under your skin and that might release medication kind of over a slower and longer period of time. So again, these new long-acting products can take a lot of different forms. And some of the products, again, as I mentioned, could be dosing up to kind of once every year. So you could have an implant under your skin and you wouldn't have to refill the implant, but once or twice a year. So that's very exciting. It really is, again, I think it's the future. There are tons of clinical trials that are underway right now, and we could have some data from some of those clinical trials in the next year and a half, both for HIV treatment, so for people living with HIV, as well as for prevention, so something like a longer acting form of PrEP. It has the ability to kind of overcome challenges that we see for, again, people adhering to their medications, taking it every day, having to store medications in their houses if you don't, want to have medication, out in places where people can see, particularly if you live with roommates or with family members. It also just, I think, can help to improve quality of life for people. I think people just feel better when they don't have to take a pill every day. I think that just, if you don't have to think about those types of things. So we've, again, released these 4 reports, and we looked at different issues. So we have a report that we have an overview report that kind of covers, kind of the big ticket items. It's something that I think any kind of community stakeholder might just want to read and kind of see what kind of the major policy issues are around long-acting HIV treatment. So after the science comes out, what do we need to be thinking about in terms of education and policy dialogues to make sure that these things are accessible to people and that they're used in ways that help us to continue to make progress on HIV and make progress for populations that are most vulnerable. But we wrote 3 separate reports looking at distinct issues. So the Food and Drug Review and Approval process, payer coverage. So when we think about payers, we're thinking about insurance, so public and private insurance. Public insurance is Medicaid and Medicare. Private insurance are, employer-based coverage, marketplaces, things like that, as well as the Ryan White program, which is, as I mentioned, is a payer of last resort, and kind of what decisions they're making to to make these new medications, which could be very expensive, to make sure that they are affordable for people. And then also just thinking about a variety of issues with respect to the market. So how do we think about adherence, and what's the research we need to be having on adherence? How do we think about making sure these types of long-acting products are acceptable to communities as well as to providers, so that they're actually using them and or recommending them, prescribing them to individuals, and also thinking about the cost as well. So FDA review, the FDA is the federal agency responsible for ensuring the safety of medical products, so things like drugs, biologics, medical devices. Once something is submitted for approval to the FDA, so a new product, usually they're submitted by a pharmaceutical manufacturer, the FDA will assess that product for its safety and for its effectiveness. And kind of the process for approval differs based on whether the product is a drug or a medical device. And so long-acting products raise a lot of questions that I think are going to be very interesting, that we need to make sure that we have answers for. And so they're going to have different chemistry, manufacturing. Yeah, please take as many as you want if you have to go. No worries. They're going to have, for products that remain in your body for a very long period of time, different chemistry, manufacturing, control measures will be required to assess their long-term safety and effectiveness. They're going to have to be able to answer questions about whether or not these long-acting products not only are safe and effective, but could they have implications for resistance? So if someone becomes resistant to this long-acting product, what that looks like. Resistance could come up more often with a long-acting product in cases where, again, like you have an implant that kind of slowly releases medication into your body. If you have cases where there's a or either where you're getting off the implant and there's still some medication in your body, so at a low level, but at a level that's not at the level of effectiveness, that's where resistance could come up. And so you need to be thinking about when people kind of transition onto and off of these types of medications. And then also multi-purpose technologies they're already being researched. So multi-purpose technologies are things that not only address HIV treatment or prevention, but also might address pregnancy, so contraception. So you could have something that a pill that not only is birth control, but also prevents HIV or is a way to treat your HIV. So you can bring those things together in terms of one product, and those could be long-acting products. So we have long-acting forms of contraception. We could match that with long-acting forms of HIV treatment and prevention. And that is, I think has a potential to, again, really just improve health and quality of life for women, but for also other populations. When you think about, again, not even just HIV prevention, but STD prevention. If there are ways to have medication forms to prevent STDs or to treat STDs, you could take one pill rather than taking multiple pills, or use one product that addresses all these issues. So we've made some recommendations in our reports that say, we need to start preparing the FDA to kind of review these different types of products that are under review. There are lots of questions that the FDA needs to consider. What are the standards and type of review that the FDA will use? Will products be eligible for expedited review so they're not delayed in terms of, expedited review is the difference between something being available in 8 months, being reviewed in an 8-month time period versus 12 months. That's a time period where communities that are heavily affected by HIV really could be using these things. So we need to make sure that the FDA see whether or not these products are eligible for expedited review programs. We want to make sure that community priorities are heard by the FDA. So there needs to be engagement. So things about, if you have concerns about resistance, concerns about when exactly could these products be available to people. We want to make sure that Congress provides adequate funding to develop long-acting products. So one of the main ways that we develop products is obviously through private industry, but also the NIH the National Institute of Health, that plays a major role. It funds a lot of research and development. They need to be properly funded to help to develop these types of interventions. The FDA also needs to be funded so that they have staff to review in a timely fashion. So if you're thinking about expedited review, that can only happen if you have the person power and the resources at the FDA. And we also need policymakers to start now. So we're trying to identify things that need to happen right now to bring together the parts of the FDA to review all the different types of products that are out there. Again, some products might be oral medications, but they could be injections, they could be implants. Those are going to necessitate interacting with different parts of the FDA. There's a device section of the FDA, there's a drug section of the FDA. They might have to work together on some of these products that might be combination products. And so we need to make sure that those types of planning and processes start to happen now. And we also need to just make sure that we have clear guidance for manufacturers and the public on kind of issues that might come up in the context of reviewing these long-acting products. And one of the issues that could come up is kind of the status of phase 3 clinical trials, which right now is the gold standard, but we know the Trump administration has at least made statements that they see moving away from phase 3 clinical trials, so just having 2 phases of clinical trials, which again could make a medication get out more quickly, but it also could raise some concerns because there's some things you can learn with a more robust clinical trial regimen in terms of safety and things like that. Payer coverage decisions. Again, payers, we're talking about insurance and things like that. Insurance has each insurance, whether it be public insurance, private insurance, different programs have different levels of discretion to determine whether and when new products are made available to people and at what level of cost sharing. And so we need to make sure that each of these programs, we'll keep it in our mind that they operate under different provisions of law, and they have different rules that regulate pharmaceutical coverage and cost sharing. So even within like Medicare, different long-acting products may be covered by different parts of the Medicare program. So we have Medicare Part B, which covers physician-administered drugs, and we have Medicare Part D, which covers most outpatient prescription drugs. And that Medicare Part D program actually has a kind of a low-income subsidy, so it's a subsidy for people who, just don't have as much money. It helps them to be able to afford coverage. We know that cost sharing in the Part B program can actually be very, very high, with beneficiaries on the Medicare program being responsible for 20% of the Medicare-approved amount of the drug. And there's also a deductible that they might have to pay, so they could be paying, $183, and that was the amount this year, which is a significant amount for many people, particularly who are low income. But again, the Part B program doesn't have a subsidy, whereas the Part D program does. When we think about cost, to the question of cost, the Ryan White program plays a role, but we want to make sure that the Ryan White program is actually filling gaps. And for a very long time, it was unclear whether the Medicaid Ryan White program could provide cost-sharing assistance for the Part B program. The Health Resources and Services Administration, HRSA, which administers the Ryan White program, just this past summer, released a policy clarification saying that they can, help with cost sharing for Medicare Part B cost. But prior to that, there was no clarification, and I think most people. All the indications from HRSA were that the Ryan White funds could not be used in that way. Those are policy issues that we need to be thinking about now in terms of what role Ryan White can play in terms of, again, being this effective payer of last resort. So again, the big takeaway is that various payers must consider in advance how they will evaluate new products, and federal agencies should consider how they will provide early guidances both to purchasers, to prescribers, and to the public about how these new products will be evaluated and integrated into drug formularies. Lastly, the key issues that I already mentioned, adherence, acceptability, cost effectiveness. Again, one of the big rationales for why long-acting products are great is because they can help with adherence. If you don't have to take a pill every day, but we need more research to show that, hey, we're actually seeing a benefit on adherence. Another kind of thing that's very important is quality of life, and there's so many considerations that need to be thought through as research is going, as well as once these products, if they are found to be safe and effective, go to the market, thinking about the possibility of side effects, thinking about injection site pain, affordability, privacy, convenience, making sure that people can just, and when I say convenience, like they can access, when they need these medications on a monthly basis. Again, they're not necessarily taking or a yearly basis, that they can get refills in an efficient way, that they can make medical appointments and do so in a convenient way where they can kind of just go in, see their doctor and get the new medications. Figuring out what's the way in which these different products might be administered. Will they be administered self-administered? That could be really great. But if they have to be administered by a doctor or nurse, that's actually adding something in that we don't currently have. Like when you take a pill every day, you go see your doctor, or now if you're living with HIV, maybe once every 3 months, once every year. But if you have like an injection that you need to do once a month, you actually might have to see your doctor more. And so that's going to create a burden on the health system. We're going to need to make sure there are providers available to do that. They're going to have cost issues associated with them. So these are all policy things that we need to be thinking about now. And providers are also going to have a lot of questions that we need to be engaging with providers to make sure that, if these products are found to be safe and effective, that providers actually, prescribe them. And they're going to have questions and concerns that need to be answered. Some of them are going to be around things like resistance. Providers often have concerns about those types of things. That was a big concern, I think, yeah, for, I mean, just new formulations of kind of antiretroviral therapies now, and it could come even more of a kind of issue with these long-acting forms. All right, and last thing, we'll finish up in the last like 5 minutes and have some time for questions if people have questions, is rapid start of antiretroviral therapy. So again, I mentioned that we release these reports. These are all on our website. You're also welcome to take some hard copies if you want. This was all on long-acting HIV treatment and prevention, and I gave a very high-level overview of all the kind of details that are in them. But these are resources that we've created, and we hope that will be helpful to you, community stakeholders, policymakers, and others. Just this week, in advance of World AIDS Day, we released actually 2 reports. This is one of them. The one that I'm going to talk about is on rapid start of antiretroviral therapy. So efforts to get people living with HIV on medications on the same day or very shortly after they get diagnosed with HIV or are re-engaged in care, because often people, they might be diagnosed at some point in their life, but then they fall out of care. They need to come back into care, and when they come back into care, we want to make sure once they see that medical doctor and they're like, oh, you have HIV, we want to make sure you're on in treatment and in care, that you receive antiretroviral medications right at that moment, right at that point of contact with care, rather than waiting until the next appointment or a month later. So we have this it's a very short big ideas paper that kind of looks at this concept, which I think is the future. We want to make sure that it is the priority for a health system to get people on care as soon as possible, because again, when people aren't brought on care right away, they often, they can be lost to care, and so we don't see them for months at a time, years, until really their health is, has deteriorated a significant amount. So again, starting people with HIV on antiretroviral therapy on the same day that they're diagnosed has been shown to decrease the time to viral suppression, and that's a major metric in terms of the health of people living with HIV. If they are virally suppressed, they can have the best health outcomes. We also know from a public health point of view, it's also good because if you are virally suppressed or have an undetectable HIV viral load, you cannot transmit the HIV virus on to your sexual partners. We know that is definitively proven. So if we can get people to viral suppression sooner, that's good for them and it's good for public health. And so we know by starting them on the same day as a diagnosis or the same day that they're re-engaged in care leads to that decrease, and also can lead to improved retention in care. And so research is happening on that. We need continued research, but it has a lot of possibilities, and that's why we've kind of signaled this out as a place for major innovation for better supporting people living with HIV. Despite the fact that we have this kind of positive thing that we know that it's good to have rapid start of antiretroviral therapy, there are numerous challenges, financial and otherwise, that just make it really difficult to make it the reality. So most clinics and programs are not, that's not the standard practice in the United States, and in most, really in any country at this point. We've signaled out in our brief kind of the role of the Ryan White program. We talked very briefly about the Ryan White program before, but it can play in terms of overcoming barriers to the adoption of rapid start of antiretroviral therapy. And we've just identified some potential actions that the Ryan White program can play. This is a very short brief, it's 4 pages, but we hope that it will be informative. It'll give some ideas for engaging with the federal government, so with Congress, with federal agencies like the Health Resources and Services Administration, HRSA, which oversees the Ryan White program, to think about what they can be doing to make rapid start of antiretroviral therapy the standard practice within our health system. And these are some of the recommendations that we've kind of come up with. You're welcome to take copies of the brief, and it's also on the O'Neill website. But we need the Ryan White program to provide critical leadership. So we need HRSA to make rapid start of antiretroviral therapy a priority. There's a lot of things that it can do to make sure that state and local health departments are moving towards making this the standard of practice. We need HRSA to measure time to ART, so we can kind of get a sense of the metrics. How long is it taking right now? How can we start to change that time to reduce it? Time to viral suppression also needs to be something that is monitored by the federal government and by the Ryan White program. We also need to prioritize funding to kind of start rapid start. We need to expedite Ryan White ADAP. So ADAP is the Age Drug Assistance Program. They provide the drugs as well as insurance. Pays for all of that at the state and local, the state level, so that people can have access to drugs and to healthcare. We need to expedite eligibility for that program. and to procure starter packs for antiretroviral therapy. So one of the kind of problems now is you can get people somewhat quickly onto the Ryan White program, but there's sometimes a gap. It takes a few weeks before they're like found to be eligible for the program, and different states have different eligibility for the Ryan White program. Having something like a presumptive eligibility so that people can get on the program and to get medications as soon as possible, that would solve so many problems. In the absence of that presumptive eligibility, which might actually require congressional reauthorization to make that happen, just in terms of how the legislation that is the basis for the Ryan White program, what it looks like. And if we're not at the point of having new legislation, having starter packs, so having a week or up to a month of kind of medication at the moment you are seeing that doctor for the first time, either to get that HIV diagnosis or to be reengaged in care, that can be, I think, a really great bridge to getting people on treatment on the same day, and also to get them retained in HIV care. So we want to make sure that we're developing models that show states how to streamline the ADAP eligibility process by identifying and disseminating best practices. We want to facilitate the purchase of starter packs. So if there's funding that can be allocated within the Ryan White program to allow states and Ryan White grantees to buy these packs, that would be something that needs to be looked at, or at least that we're recommending. We need to support practice transformation. So when we identify these new models, one way in which we have done that through the Ryan White program is through the Special Projects of National Significance program, as well as through the AIDS Education and Training Centers program. We need to fund those to really focus on Rapid Start and developing these new models. And again, there might at some point be a need for Congress to act, so to have congressional authorization that really kind of focuses on how we can better support Rapid Start of ART. And so when Congress next reauthorizes the Ryan White program, making sure that we're kind of thinking about these innovative practices that can really have a big impact for people living with HIV, and also have a big impact for prevention of HIV transmission. So that was a lot of information. It's about an hour, so thank you guys for bearing with me. Do you guys have any questions? Are there anything that's raised by anything I said?
Thanks so much for your talk. My question is about the first part of what you were saying about molecular data and technology.
Mm-hmm.
Is this being used only in the US, or do you know if it's also being developed in other countries?
I don't have enough expertise. It is being used. I mean, molecular surveillance isn't unique to the United States. Again, the basis for molecular surveillance has kind of been there for some time. We've been doing resistance testing for people living with HIV to make sure they can get on, medications that they're not resistant to, that are going to be the best for them. And that information, often gets reported to health entities. So it has existed. We're now able to kind of, again, see those connections between the molecular sequences and collect that data in such a large way where we can kind of inform, public health interventions. And so it is something that I think is being looked at by other jurisdictions and other states and countries as well. So.
How do these plans or projects or whatever it is, how does that affect children who have the virus either through birth or they contract it the way that Ryan did? How does that work? Is it the same process that is applied, or is it modified because their immune system may not be as developed as adults? How does that work?
What are you specifically talking about? Are you talking about with respect to long-acting HIV? Are you talking about molecular surveillance or something?
As far as them getting treatment and getting the right kind of treatment, is it modified or is it just kind of like a blanket treatment process for everyone?
No, there are treatment guidelines that are specific to infants and adolescents that the CDC has promoted, and they're different from adults. And so, a clinician who is a pediatrician or would be working with someone, say under the age of 16 or something, they would need to follow those treatment guidelines. So they are slightly different.
In the context of the HIV-specific criminal laws and trying to roll those back and those, is that sort of discussed at all or your efforts in terms of larger criminal justice reform? The Congress is not sort of being a driver for instance registration, but as there's even bipartisan support in reducing our number of people incarcerated, and this is the part of both ways incarcerated people, does that, do those sort of merge, those discussions?
Yeah, they do. So there's like there are a number of advocates at the state level, community and state level, that are kind of working on issues, but there are also people at the federal level. So there's a kind of based in DC, but people kind of kind of are in part of this coalition across the country. There's a HIV and LGBT criminal justice kind of working group that has been in existence for at least since it's 2010. They work directly with a lot of other kind of criminal justice. So there's a criminal justice roundtable in DC that kind of does, they're the ones, advocates that are behind a lot of working, lobbying Congress, working with Congress to kind of move forward a lot of this legislation. Kind of HIV, kind of criminal justice folks and LGBT criminal justice folks are engaged with those people very much so. And in terms of like the solutions to HIV criminalization, I think they have to be situated in kind of broader criminal justice reform. As I mentioned before, like it doesn't make sense. You can't just like get rid of the HIV criminal laws and think you're going to be better, because again, like those other criminal laws exist and could be used. So we need to make sure that we're talking more broadly about criminalization and things that lead to arrest and conviction. But there's also just like another issue that I've done some kind of talking about just to raise awareness about. One way in which people have been thinking about reforming HIV criminal laws is to incorporate all the science, the new kind of developments in HIV. And one of the developments is the idea that when I said people who are virally suppressed, they can't transmit the virus onto others. That's a huge thing. It's something we've known, at least intuitively for some time. We now have just such a robust amount of clinical and real world evidence that supports that. That raises the question of how that fact, so viral suppression as leading to prevention, how that could be incorporated into criminal laws. And I think I wouldn't say there are efforts to reform criminal laws based purely on that, but people have tried to incorporate that doctrine as the way of modernizing the laws. So there was at least one state, and again, this wasn't what advocates were, this wasn't what they were shooting for, but the compromise that they were ultimately able to get in North Carolina was to modernize, to reform their criminal laws by saying, okay, we have this HIV criminal statute, people are being prosecuted under it, we're going to say anyone who is virally suppressed, they are excluded from prosecution, which helps the people who are virally suppressed. It leaves everyone who's not virally suppressed still vulnerable to prosecution. Those are, when you think about just where we are in terms of the progress we've made on HIV, we've made a lot of it in a lot of different areas. We still haven't made enough progress for many of the populations most vulnerable. So whether they be Black and Latinx communities and folks, trans individuals, low-income people, particularly people who are unstably housed, people in certain parts of the country. We haven't been as effective in the South. So we're seeing places where, okay, if you were to reform HIV criminal laws to incorporate this viral suppression concept, which has also been, we also refer to as U equals U, so undetectable equals untransmittable. That can raise a lot of questions, and it can actually lead to, and maybe even exacerbate disparities and lead to harms for particular populations. And so, so in terms of how you reform those laws, it definitely needs to be situated into broader criminal justice reform, but like it also can't be thought about in certain ways that actually could lead to an actual worsening of the problem. So it's a great question, and it's definitely something I think about a lot. All right, well, if there's no other questions, I think we'll wrap up. Thank you all for your attention. Yes, feel free to take copies of that. It's also on our website if you want copies. So they're already in folders, the 4 reports. Yay! Hey, Sonia, would you mind taking a picture with me on this? I'll have that for some other thing. Let me put this back up to actual.
Covers.
Yeah, get me with it. All right, thank you.
Take those back.
Yes, we can take that back, and people want to y'all want to eat it. I haven't eaten it fully, so. Yeah, I'm glad people showed up. That's good. How was that? Was that helpful? Did you learn something? Was it okay?
Yeah, I realized. So, yeah, the other night I was watching, not only stand up, this is like documentaries that are based on
Yeah.
I have one in the 90s. I think it was the 90s, or one like, I don't know.
Yeah.
The point was that they talked about HIV epidemic,
Yeah.
the way that it like broke and when it like how that had like so that was like really interesting. Like the daily stories. Like NIH,
Yeah.
everything that happens, CDC, like all the confusion about it, and I was like, oh my god, it's so far, there's so much.
Yeah, that's the mechanism that got us to where we are. I mean, for a very long time, we just did not have research. We didn't have funding. We didn't care about, again, mostly people who are gay, bisexual, drug users, populations that are not, just are not viewed as deserving. I mean, Ryan White is obviously.
Can I have another one?
Yeah, please have as much.
We're gonna take it back to the office too, and I'm sure welcome back.
I can help you.
Thank you again for coming. I hope that was helpful or interesting. I really appreciate you being here.
I
Yeah.
think I'm gonna cut it in Colombia.
Good luck with the exams.
I need that.
Because I'm a little
You'll do
bit
good. You'll
like.
do it. Put the work in. You'll do
You
it.
want me to help you to carry this?
Sorry, Marian, but can I please have?
Oh my god, yeah, please do. Yeah, and it was like super interesting, and they had like some other community organizers and leaders, like, documentary, and like they were like, walk down the street, less than 1 people will be there.
Yeah, a whole generation of, yeah, particularly gay men, trans men and women who we just don't have because I mean, it wasn't necessary. We could have had a response from the very beginning, but there just wasn't any. I mean, the president didn't even use the word HIV until
Right,
like
they
5
talked-
years
they
into the
talked
HIV
about
epidemic.
that too.
Like,
It is a never-ending
so-
problem from another, group of things that we should be able to handle
Yeah.
now easily.
Yeah.
But yeah, that's something we do not learn as
Yeah.
Muslims. We should. So do you want me to help this to continue?
Yeah, maybe, and like, I don't.
And
We
then
have
I
bags,
can
we have bags that we can still, yeah.
And then I
We have
can
bags.
So,
Okay.
okay, so I guess you know what advertising is, what is
PrEP is pre-exposure prophylaxis, so it's a pill that people who are HIV negative but at risk for HIV, they can take every day, and if they take it as prescribed, it reduces their risk significantly. So it's up to 100% effective in terms of preventing HIV.
So what does that mean? Is it just because you have like lymphocytes or?
Yes, I mean that would be.
Like your immune system is I mean, like I didn't understand like that part because like that's what I had seen.
Yeah.
But then I was like, I mean.
Who's vulnerable? Everyone in some ways is
Right,
vulnerable to
like,
HIV. They have different recommendations for different populations. So you are more likely to come in contact with HIV if you are having sex in the gay, if you're a gay man. Like there's enough gay people who have HIV. You're more likely to come in contact with those individuals. Also, the type of sex that gay people have. Some gay people have. Anal sex is higher risk for HIV transmission, just in terms of the anal membrane is just more susceptible to kind of tearing and for HIV transmission compared to vaginal sex. And so so there are many recommendations that for gay men that are just that look different than for heterosexuals or for people who use and inject drugs. So there are different there are different recommendations for each of those populations. But all of them could benefit from it. And there are many heterosexuals who should be on PrEP as well. And I mean, I wouldn't say everyone should be on it just because it costs a lot of money. In terms of just again, if you don't have to take a medication, I would just probably don't take it.
Unless there is a risk or you
But yeah,
know
but
that
if there is
maybe
an actual
you're
risk, so we
vulnerable.
need
But
providers
do you
to
know how
talk.
powerful this information is? And this is now, for a while.
Yeah.
You know how many, I just knew this year when I started working in the
Yeah.
UNAIDS as an extern. This woman, Huffman, I just don't remember her name, her first name, whatever. She explained me that HIV
people that have like normal relationships and that your partner
Yeah.
can have just preventive treatment and not get infected.
Yeah.
This is so powerful. I
It's
didn't
very
know
powerful.
that. Yes.
Yeah. No, it's exciting. I mean, for a lot of reasons. I mean, the first thing, I mean, PrEP is hugely exciting. I think it's very empowering for people, who are not living with HIV, but they can have sex with someone who they don't know their status or who's living with HIV. And so I think it's a major way to just destigmatize HIV and to empower people and to make people not be afraid they're always going to get HIV when they're having sex. So it reduces anxiety, it promotes health. It's just good on so many levels. And similarly, this idea of U equals U, so undetectable equals untransmittable. So if you're virally suppressed, if you have an undetectable viral load, you can't transmit the virus. That is also just such a, I think it's such an important thing for so many people living with HIV who often are thought about often as just vectors of transmission of HIV. Like the idea that you can be virally suppressed and you can't transmit it is so powerful for them. They don't have to worry about, again, hopefully it destigmatizes just like their experiences, but also when they're just with their partners, they don't have to worry that there's any chance of transmission, and that's huge. So getting the word out about that is, I think it's very key. There's actually a movement led by people living with HIV. This whole U equals U. They have a campaign that is to just raise awareness in the U.S. but all over the world about this, because a lot of people don't know. I mean, that's just we don't talk about HIV enough. So hopefully if this was helpful to you or interesting, I'm glad to be able to do something for World AIDS Day, and thank you guys for coming and supporting. I will pack up my stuff
Do
as
you
well.
know if this cones and drinks are used too?
I think they may have brought them, or someone from Boston may have brought them. They sponsor, but I think they'll take them back with them. So I'll check. Thank you again for all your help. I'm so happy that this turned out well. Hi, are you guys from Boston?
Yes, I'm sorry I came in at the tail end, but I wanted to show my face. I'm Kristen.
Hi, I'm Sean.
Nice to meet you,
Nice to
Sean.
meet you.
How was it?
It was great. It's good. Hang out.
Good.
And,
I know
just happy
Alex was able to show. Was Alex able
Yeah,
to
she
show?
was here for various points. So,
Okay, okay, cool, cool.
That's great.
Good, well, I'm glad that, it's not the high show to see the full presentation.
So it was recorded. It'll get easy to get edited and make sure we have like captions and everything.
Yeah,
That's
if you
there.
wanna
We'll have it
send
on our
it
website.
to,
It's awesome.
Yeah, and I'll definitely go ahead and put it possible as some folks are gonna make them come out and support it. So.
Yeah. So thank you again for the support, you guys.
Yeah.
Co-sponsored last year. I
Yeah,
appreciate
yeah,
the support.
yeah.
It's a very important issue. Definitely impacts Black people, communities of color, and lots of other populations. And I'd love you to take advantage of all these data.
Yeah.
Just get this information
Yeah,
out.
well, thank you for doing this, I really appreciate it.
And I went to Georgetown, so I'm
Yes,
Boston
I know,
alum,
I
so,
saw. Yeah, nah, well, that's good, I'm glad to see Boston people still around.
And please tell people, particularly those interested in health, but also just like if I can be a resource just to Boston.
Yeah, definitely, I will let them know, thanks, Sean.
Thank you. And I guess these are your drinks. Did you get from these? Or maybe
It looks like it, so I can take it
yeah,
back to
please
my
feel free to.
office.
Yes. Thank you so much
You're
again for all of
welcome.
this. Okay. Oh, I gotta turn it off.